very hard to fight or to give a simple therapy that can overcome this one. The structure of the receptor binding gene region is very similar to that with SARS coronavirus and also with MERS-CoV, which we had before in 2013. But now the angiotensin converting enzyme is the receptors that for cell entry. So we will talk a little bit about ACE inhibitors and ARBs. The closest RNA sequence similarity is to that found in bat coronavirus. That's why they expect that it is from bats. This one, positive sense RNA virus. This means it's very easy to attach to the cells, unfortunately, to enter the cell and replicate inside the cell. So it's very dangerous issue we are dealing with, and the spread, as you know, all of you know, will be very high. As we are expecting, we can see now according to the numbers. Unfortunately, but it's not easy to treat because there's many advantages. It will replicate very fast, it will spread very fast, so it's not easy to treat. By the way, regarding to the mortality, it's low, but the spread is very high. This is not like the MERS-CoV. The spread was much lower, but the mortality was much higher, or up to limit higher than this virus. But as we are talking about COVID-19, now the biggest problem and the biggest challenge with the spread. Severe illness can occur for any age. It's not only contagious for those elderly people, but with those patients with comorbidities and elderly, it may have more complicated issue, and it may come with other treatment challenge. We are talking about treatment challenge because sometimes we cannot give some treatments for those patients with a lot of comorbidities. So for younger patients, they have higher chance to treat or to have no sign and symptoms because there is no comorbidities. But for any age, it can affect. Next, okay. Another issue, as I told you, comorbidities is a challenge. Another challenge, the challenge that usually FDA needs or companies needs 12 years to have the FDA approval between trials, safety, efficacy, and clinical trials, and post-clinical trials also studies. But the problem here, we have no time, and we are in a big challenge. So we have something called fast-track acceptance. This is used only for unapproved medical countermeasures or unapproved use. Any medication you can use it, and after the FDA approval as a fast track. There is even some medications we are using without FDA approval because we have no time to get this one. But also regarding vaccines, we cannot expect that we will have it within 1 to 2 or 2-3 months. I think at least a year if we can. But unfortunately, we have a bad experience with SARS and MERS-CoV. We couldn't reach any vaccination for those viruses, and maybe we can for this COVID-19, hopefully, but it's not a promising issue. According to management, we have 2 levels. We have home care and we have hospital care. For home care, usually the biggest issue that to focus on prevention of transmission to others and to treat silent symptoms and keep good hydration, to give antibiotics and analgesics, and that's it. But for hospital care, there is the debate. We have glucocorticosteroids, nebulized medications, NSAIDs, antimalarial, antiviral, interleukin 6 pathway inhibitor, convalescent plasma, vitamin C, and zinc. There is some of those are supplement like vitamin C, zinc. Others maybe like interleukin 6 pathway. They are trying to reduce complications and septic issue regarding to the infection. There is other medications to prevent or not to use like glucocorticosteroids and nebulized medications. We will start with the glucocorticoids. Of course, there is a lot of debate, but the final issue, you should not use glucocorticoids as a standard therapy. It should be used only for some patients which needs corticosteroids, not regarding coronavirus. For those patients with COPD exacerbation, asthma, or those patients already on corticosteroids or need for this exacerbation. But regarding to coronavirus, you should not use. Even for SARS, there was a good result with corticosteroids. In normal influenza, mortality will be higher, and there is delayed viral clearance for patients with MERS-CoV. So we have two bad experiences and one good. But for glucocorticosteroids now here in COVID-19, the WHO and CDC recommend not to be used. But there is specific patients, of course, those patients with COPD exacerbation. And another thing regarding to coronavirus, this one COVID-19, that for those patients with ARDS, but very severe ARDS, VO2 to FiO2 ratio, less than 100. Here you can use some corticosteroids, but for ARDS issue, even ARDS is caused by the COVID-19, but now we are using this one for ARDS issue and under ICU consultant supervision. Also for some patients with septic shock, maybe we can use small dose of hydrocortisone, 100 milligram Q6 hours for the sake of septic shock. Okay. As a conclusion, you should not use as a standard therapy. We can use it for those patients with asthma or COPD, and we can use it in the ICU after a consultant approval for patients in septic shock and for patients with ARDS. Okay. Now, nebulized medications, I think Dr. Tasmia, she told you about that it's aerosol generating procedure and should not be used for the sake of safety. If we have to give those nebulizers, we will shift to meter dose inhaler dosage form. Those meter dose inhaler will be much lower generating aerosol. And if we have supplement therapy or another therapy, adjunctive therapy, like some antibiotics we are giving by nebulizer, we have to stop those antibiotics or to stop those therapy, and should not be given for those patients with active COVID-19. So usually we are only giving the necessary medication by meter dose inhaler. Any nebulizer you should stop if you can. Regarding WHO, they on 18 March they mentioned that using NSAIDs may complicate the issue, and they may you should not take any ibuprofen or NSAIDs, but they again came back with another message that there is no issue to use ibuprofen or any NSAIDs, especially if the patient is a chronic patient on those medications and he or they need to continue on those. So before there was a big debate, but they prefer to hold or not to give any of the NSAIDs regarding to those to this study or some expert opinion from French clinicians. They suggest that the use of NSAIDs may have negative impact on disease outcome. And they mentioned there's some young patients, they have or experienced severe disease while they are using NSAID. But after looking to the data, the EMA and WHO, they recommend that NSAIDs can be should not be avoided, and it can be used when clinically indicated. Of course, because of the side effects of NSAIDs, if unnecessary, there's not necessary to be given, we can start acetaminophen as the first line therapy as antibiotic, but you can still use NSAID and ibuprofen with the lowest effective dose. And for those patients with a chronic illness, they can continue using NSAIDs unless there is another contraindication like GI bleeding or renal injury, acute kidney injury. Now, the big topic regarding chloroquine and hydroxychloroquine, we have a very good experience. I think since 1945 we are using, or it's known to be used to minimize symptoms of inflammatory immune diseases such as lupus or rheumatoid arthritis, and well-known effect and side effect of those medications. But in vitro, they found hydroxychloroquine and chloroquine can prevent the SARS-CoV and SARS-CoV-2 viruses from attaching to and entering cells. Of course, we have the parent medications and we have metabolites. Both of them, they can affect the in vitro, the entering of the cell of the COVID-19. But unfortunately, there is many side effects can occur. So we are preferring to check, or you have to check ECG, to have an ECG, then to find the QT interval. If the patient is risky to have a QT prolongation and his age is under 40, and there is no respiratory signs and symptoms, it's not preferred to start those agents because the risk outweigh the benefit, because of course, specifically if the QT greater than 500 milliseconds. But if the QT is greater than 500 milliseconds, but the patient in advanced age, immunocompromised, or a life-saving issue, we can use hydroxychloroquine or chloroquine, but we need to activate cardiology also. So as a conclusion, it's a well-known drug, but there is many side effects. Main issue regarding Q2 prolongation, prolongation, you have to do ECG. If the QT more than 500 milliseconds, you should rethink again. If the patient is than 40 and asymptomatic, it's preferred not to be started. But if more than 500 milliseconds or less than 500 milliseconds and the patient immunocompromised, respiratory signs, symptoms, or in severe disease, advanced age, it's preferred to be started. Till now, I am expecting to have a different recommendation because there is some studies regarding hydroxychloroquine and chloroquine. Till now, you have to start and to activate cardiology, our cardiologist. Both of them have have efficacy, but hydroxychloroquine appears to have more potent antiviral. That's why it's the first line agent, and if not available, you can use the chloroquine. Of course, this one fast-tracked approval for this indication, and there is no previous FDA approval for coronavirus or indication for coronavirus with those medications, but with COVID-19, we have the fast track to be used. Optimal dose, usually we are giving 800 milligram on day one, then 400 milligram daily, which is 400 milligram BID on day one, then 200 milligram BID after that. For chloroquine, you should know the salt, and you should check the salt. Of course, we are talking about the chloroquine base. So according to this, you have to convert, but usually for chloroquine, we are giving 1 gram day one, then 500 milligram daily, which is 500 BID, then 200 BID. If there is another form or salt, please ask the clinical pharmacist to adjust the dose. Okay. This is the study still in print or in press. It's not published yet, but they, according to this randomized study, hydroxychloroquine is better than chloroquine. Okay. Regarding side effects, more than 90% of the patient will not have any QT prolongation or side effect, but you have to do ECG and to check another medications. May it cause also drug-drug interaction or QT prolongation. Also, you have to reduce the dose or to decrease the dose. By the way, yesterday there was a guideline, published guideline regarding the COVID-19, and they recommend against use of azithromycin with hydroxychloroquine together for the patient, unless there is suspected CAP. If you are treating CAP, it's okay to give macrolides with hydroxychloroquine for COVID-19. Okay, drug toxicity is high, as we mentioned, so you have to monitor the side effect, drug-drug interaction, and try to minimize the drugs that can cause toxicity and QT prolongation. Examples of this one. Okay, here we have the ophthalmic retinopathy. We have also hemolysis, especially for those patients with G6PD, especially with the chloroquine. For hydroxychloroquine, much lower incidence of hemolysis. Leukopenia, thrombocytopenia, and hypoglycemia is an important issue because for those patients with insulin dependent, most of them will have hypoglycemia after using chloroquine and hydroxychloroquine. Of course, ECG you have to monitor, and QT prolongation, ventricular arrhythmia, bronchospasm, and abnormal hepatic function test. To reduce the risk of side effects usually, and for those patients with QT prolongation, we will check first QRS. If QRS is less than 120, we will accept with the use of the QT of the hydroxychloroquine or chloroquine with a QT less than 470. Immediately you can start. And you will start with caution and try to decrease any other agents that cause a QT if it is between 470 to 500. But if the QT more than 500, maybe you have to start if it's life-saving issue or severe respiratory symptoms, silent symptoms, but you have to activate cardiology immediately. If the QT increased more than 50, immediately you have to discontinue and call cardio and ID. Okay, regarding to those with QRS more than 120, we will accept to start immediately if the QT is than 520, and you have to start with caution and try to discontinue any other medication that cause QT if it's between 520 to 550. Between 520 to 550, you have to start with caution, or you can start with caution. But with more than 550, do not start until cardiology will come. And again, if there's any increase more than 50, please reduce or discontinue. But we have no evidence to reduce the dose here, so we have to discontinue. Again, here the same, almost the same, but you have to check electrolytes. Yeah, in addition to those drug-drug interaction, try to optimize electrolytes, magnesium and potassium. Before you start that, you will have lower rate of QT prolongation. For remdesivir, it's a promising drug, but unfortunately, it's not an ICU drug. It's a IV medication, novel nucleotide analog that has activity against COVID-19 in vitro. Usually, the standard dose 200 stat dose, 200 milligram, then 100 milligram OD, but specific durations not known till now, from 2 to 10 days. It's a broad spectrum antiviral, but there is a lot of exclusion or contraindication criteria. There is two main disadvantages in this drug. The first thing, cyclodextrin vehicle. So we cannot use with those patients with severe renal impairment. The second thing, because of the toxicity of this cyclodextrin. The second thing, a lot of exclusion criteria, and you should not use remdesivir, or there is no evidence to be used in those patients, like those with need inotropic, creatinine clearances than 30, dialysis or hemofiltration, high liver enzymes more than 5, and another use of another antiviral. So as you see, there is a lot of exclusion. That's why I mentioned it's not an ICU agent, because you can find many of those exclusions with one ICU patient. And each of them is enough to not use. For lopinavir and ritonavir, unfortunately, there is some data, they claim that there is no benefit and no rule in the treatment of COVID-19 or SARS-CoV-2 with this combination, antiviral combination. It's a protease inhibitor used usually or primary for HIV infection, some in vitro activity against SARS-CoV-2, but SARS-CoV-19 or CoV-2. So, but unfortunately, according to this study, there was no rule and no benefit of using lopinavir ritonavir. Again, in the last updated guideline yesterday, they mentioned they are against the regular use of lopinavir ritonavir. Another hopeful drug, but it's only found in Asian countries, favipiravir. This Japanese, there was Japanese experience with this drug, and it's RNA polymerase inhibitor. There was a much faster rate of viral clearance, 4 versus 11, and more frequent radiographic improvement, also great improvement, but there are some limitations with this use. There's no randomized studies, and the result should be interpreted cautionally. You cannot use it for any patient. And I think the severity of the patient was not, it was not ICU patients. That's why we need to use and we are waiting for another studies, but we need to use with caution favipiravir drug. For absolute contraindications in pregnancy, and even for men, if for male must avoid intercourse for 4 weeks if they used favipiravir. Convalescent plasma, a few cases among those or the previous days or months. It's till now it's effective, but SARS and MERS-CoV trial and experience was not that promising, but till now, according to the data, we have a good number, let's say success number. Most of them usually need nasal cannula, not ventilator, but for some, almost 7 patients with ventilators, also they improve. But there is some logistic issues and challenges to find appropriate donors and establish testing to confirm neutralizing activity of a plasma, and some logistic issue, but we are still waiting more data regarding to this. Now, interleukin-6 pathway, as I mentioned, it's not inhibitor, of course. It's not a drug for COVID-19. It's for the complication of the COVID-19, cytokine release syndrome. Tocilizumab is the drug we are using with a specific dose, but you can give up to 3 times only, and it was efficient to decrease cytokine release syndrome, which is one of the most fatal complication of COVID-19. So there's a room to its use, and it's one of the MOH protocol for COVID-19 medication. So I think there is a rule, but only in the last stage, severe and critical patients to prevent cytokine release syndrome. The use of vitamin C, there is no studies related or connecting COVID-19 with vitamin C, but we have there is studies with COVID-19 with vitamin C and ventilated patients. We found that the use of vitamin C may reduce length of stay in the ICU and may reduce the ventilator days in the ICU. So especially for ARDS patients, we are talking about same complication, the ARDS. So using vitamin C for those patients may be helpful. So we are generally recommend to be used, and in our KSMC protocol, we mentioned that we can use it for all patients, but very high doses rather than we are taking daily. We are reaching 6 grams per day. Some studies reached 18 grams per day. For zinc, it's not preferred to be given. It's a toxic drug. If given a lot, may be toxic and may cause copper deficiency, anemia, and damage to the nervous system. So it's not preferred to be used. It was before. There's some argue about this, but no studies have been performed testing and link between COVID-19 and zinc sulfate. Now I will finish with the MOH protocol. You can see that asymptomatic patient not required to have any treatment. Maybe symptomatic relief, or if there are symptoms here from the mild to moderate, you have to treat symptoms and to consider start hydroxychloroquine. If hydroxychloroquine is not available, you can start the chloroquine. Okay. For those patients, we have to check some issues regarding G6PD, if we will start chloroquine or hydroxychloroquine, ECG, if there is a drug-drug interaction, if there is use of insulin. So we have to check those criteria before we start to avoid side effect. For severe patients, we may start treatment for antibiotics and antifungal in this step. And we may add lopinavir, ritonavir. I think in the next version of this protocol, they will remove this step. But yesterday, they recommend against the regular use of lopinavir, ritonavir. But till now, it's in the MOH protocol. You can use 400 milligram, 2 tablets, Q12 hours for up to 10 days. Of course, according to our protocol, it needs ID approval. For critical patients, so we have asymptomatic, mild to moderate, severe, and critical. For those critical patients with ARDS sepsis, you can use tocilizumab. Of course, you may add antifungal and antibacterial as in severe. And once available, we can add remdesivir or favipiravir if there is no contraindications and if they are available. So, and last thing for cytokine release syndrome, if confirmed, you can use tocilizumab up to 3 doses. Now, regarding anticoagulation, there is also a big debate regarding to this, but usually we are, for this indication, COVID-19, we are recommending to use higher doses than normal with the enoxaparin. Even higher than this in our protocol, KSMC protocol, they have higher doses than those doses, but in general, you can see the difference that for usual patient with low D dimer, 40 milligram OD, high weight, 100 to 150, 40 milligram BID, more than 150, 60 milligram BID. For high D dimer, here you will increase to 80 milligram twice daily if the weight between 100 to 150, and for weight more than 150, enoxaparin 120 milligram Q12 hours. Thank you. This is the end of my first lecture.
Thank you, Dr. Bashir. It's a very informative lecture. Just as the second lecture with you, so we'll keep all the questions at the end of your lecture, but you have 25 minutes just to
okay.
time.
I will go.
So now we will go for sedation protocol in COVID-19. So we can start.
Welcome again. I will talk about ICU medications in general. We have two parts, vasopressors and inotropes, and for sedation. For vasopressors and inotropes, we have to differentiate between those two drugs. It's not the same. For vasopressors, we are giving to make vasoconstriction, and for inotropes, we are giving to make or to increase the contractility. So we have to assess which type of shock we have. If it's vasoactivity, vasodilatory shock, which we have here with COVID-19, we need to use a primary agent vasopressor. If we have cardiogenic issue, we have to use inotrope. So we need to have some parameters. Those will tell us that we have this type of shock or not. I think it was explained in details with Dr. Ahmed, but I will try to go briefly. We need to check MAP to identify that we have shock or not. We need to check cardiac index if it's cardiogenic shock or another type of shock. And we have CVB to check the amount of fluids or intravascular amount of fluids. And we have, last thing, systemic vascular resistance. This one can be measured to tell us if there is vasodilation or vasoconstriction. So we need to follow those three, let's say, organs, or three organs we need to follow to check the perfusion. If we are treating shock, you need to check the outcomes. The outcome will be clear easily from checking the CNS, mentation, and skin and kidney function. If there is hypoperfusion, you will find the problem with mentation, cold skin, and low urine output, less than 0.5 ml per kg per hour. So, of course, hyperlactemia will be there also. Now, we are trying to give vasopressors or inotropes to treat any type of shock, to minimize permanent tissue organ damage. So the intervention should be fast, and it's very important. Before the patient collapsed, the patient will have some actions that will try to compensate, like endogenous vasopressin release and formation of angiotensin II. Those both actions can be done to increase the oxygen delivery before the patient collapses. But if those fail, the patient will come to the ICU with hemodynamic instability. Types of shock: hypovolemic, obstructive, distributive, or vasodilatory cardiogenic. Here, I want you only to check last two rows. The resuscitation, you will have low CVB, that means low intravascular fluids. That's why we have to give bolus of fluids before we start. And you will have low systemic vascular resistance, so there is low vasoconstriction. After resuscitation with the fluids, now we have good intravascular, and we can give vasopressor to increase this one, the systemic vascular resistance. Now, regarding vasopressors, as I mentioned, those to increase MAP by making vasoconstriction. Regarding inotropes, increase MAP through increased cardiac contractility. For hypovolemia, should be corrected before you will start any vasopressors. Why? Because you have not to compress empty bank. If you will compress the vessels without any fluids, you will get no benefit. You will have only the side effect of the drug. So initial, you have to replace with IV fluids. Regarding to those vasopressors and inotropes, they are working on adrenergic receptors like alpha-1, beta-1, beta-2, and dopamine. For alpha-1, the most potent vasoconstrictive receptor. So those medication like norepinephrine, epinephrine, phenylephrine will act on alpha-1. They will have a potent and good vasoconstriction. For beta-1, in the heart, they will increase inotropy and chronotropy. So the heart rate will be increased and the contractility will be increased. For beta-2, this is against alpha-1 effect. So it's vasodilatory. So you will have some agents, it will affect beta-2. This will reduce the vasoconstriction and will cause vasodilation that may have some hypotensive effect. Okay. Dopamine, we are no longer using dopamine. I will not waste your time with this one, but you need to know that with those patients with bradycardia shock, those patients with shock and bradycardia, dopamine can be used. Other uses, we are not using dopamine for any of our patients. For norepinephrine, as I mentioned, COVID-19, vasodilatory shock, so septic shock, we need to use vasopressors. The most potent and the safest vasopressor is norepinephrine. So the drug of choice here we have norepinephrine. Alpha effect and beta, but the alpha effect is more than beta. That's why you can give it, you can give norepinephrine for most of the patients safely. You will have good vasoconstriction by alpha and a little tachyarrhythmia and a little increase in cardiac contractility. By the way, we need this increase. That's why it's the safest. The perfusion will be perfect and it's better than epinephrine perfusion. The perfusion of epinephrine will be low for some tissues. That's why you will find more side effects. So the most preferred agent or the drug of choice for septic shock is norepinephrine. It's a potent vasoconstrictor, has some effect on the heart. It's helpful effect, no major side effects. So norepinephrine is the preferred vasopressor for the treatment of septic shock. Regarding epinephrine, also same receptors but different potential. It's a potent vasoconstrictor, but it's not like norepinephrine. The alpha effect equal beta effect. So the higher vasoconstriction you want, you will have higher side effect, cardiac side effects. That's why more heart rate and tachyarrhythmia, and it may cause a cardiac issue and MI. So it's a good option, but it's not safe like the norepinephrine. Can be used if we failed with norepinephrine alone. Another advantage for epinephrine is that it is the drug of choice for anaphylaxis. Why? Because it will increase, of course, vasoconstriction by alpha effect. It will increase cardiac contractility and chronotropy by the beta-1 effect. And it has some beta-2 effect will increase bronchodilation. And for those patients with anaphylaxis, this is a very beneficial advantage. So it's still the drug of choice for anaphylaxis. But with COVID-19, we have septic shock, so the drug of choice will be norepinephrine. For dopamine, as I mentioned, I will not talk a lot, but a lot of side effects. In 2012, we used to use dopamine in the same level with norepinephrine because both are vasoconstrictive agent and will have some cardiac issue. But after head-to-head study, they found a lot of more mortality with dopamine, morbidity and mortality because of the cardiac side effects. So it will cause more tachyarrhythmia, and it's out of our favor, and it's the last choice to be used unless we have bradycardia with the shock. Dobutamine, this one not vasopressor. This is inotropic agent. Its effect mainly on the heart by beta-1, but it may affect the vessels by the beta-2, but unfortunately this is vasodilation effect, not vasoconstrictive effect. By the way, it may be helpful for the heart to decrease the afterload, but sometimes you can see hypotension with dopamine. But dopamine affecting beta-1, so high contractility, but also you will expect high heart rate. So dobutamine effect, higher contractility, higher heart rate, and tachyarrhythmia, and vasodilation. This is the effect of dobutamine. For those patients mixed septic shock, there is vasodilatation, and cardiogenic shock, we are adding two agents, not one. We are adding norepinephrine and dobutamine, one for vasoconstriction and the other one for cardiac or cardiogenic shock. So there is tachyarrhythmia, it's beta-1 receptor, and there is hypotension sometimes secondary to beta-2 effect. Vasopressin, there is no cardiac effect. It's only affected affecting the vessels. So it will cause good and potent vasoconstriction, but it's not safe like norepinephrine. The norepinephrine will cause vasoconstriction and it will help the heart function by the beta 1 effect. But here we are only causing vasoconstriction, and this will end with maybe we will have a cardiac ischemia and reduced GI blood flow even at low doses. So it's not the safest. Norepinephrine still the safest, and this one can be added to norepinephrine if we are using high doses of norepinephrine, or we fail with norepinephrine alone. So the second agent will be used, this one, vasopressin, because it's mainly vasoconstrictive agent, and with high doses of norepinephrine, usually we have some cardiogenic side effects. So this one is good and safe. We are, by the way, we are calling this vasopressin the NORAD sparing agent, because once we are adding, or once we add vasopressin, usually we will have a reduction in the norepinephrine, a good reduction in norepinephrine dose. So we will move to the route of administration. Of course, you know that central line should be used via a central line because of the side effect, but in some situations where the MAP is very low and the patient is dying, we can use peripheral access and to give vasopressors through until we secure a central line. But usually we need to give via must be given via central line. Resuscitation, as I mentioned, never compress in empty bank. We have to give good volume resuscitation crystalloids before we start any vasopressors. But again, with severe hypotension and patients dying, sometimes we are starting both together. We are starting IV fluids and vasopressors together. When we reach good MAP, we will withdraw with what? With vasopressors. So it's a temporary use with, if we need it again, we can resume, but the use is, first you should use the resuscitation with IV fluids. Okay. What's the biggest advantage for any vasopressor and inotrope to be selected is the safety. As I mentioned, most of them are potent, but side effects is a lot. So we are trying to use with the safest drug we can. So usually we are giving norepinephrine as the drug of choice for all septic shock patients. And as inotrope, we are giving dobutamine. This is for your information only as a reference. This is the doses for all vasopressors and inotropes. You can review later if you want. This is about dobutamine, milrinone. And the last thing I want to talk about here for vasopressors, the phenylephrine. Phenylephrine is an expensive agent. Usually we are using because it's alpha 1 and there is no cardiac effect. So we are using for those patients with tachyarrhythmia from norepinephrine. The first agent to be used, norepinephrine. If there is tachyarrhythmia, we cannot shift to epinephrine. We will have more tachyarrhythmia. And phenylephrine is alpha 1 effect, so it's very potent. So we are shifting from norepinephrine to phenylephrine if we have tachyarrhythmia. This is a summary for agents you need to use. I will go to the second part because we have no time, only I think 7 minutes. For BAD, this is the pain, agitation, and delirium. And for pain, most of our patients are complaining from pain. The most traumatic memory of their ICU stay, up to 80% of ICU patients report pain as uncontrolled during ICU stay, so we have a big problem. And the most critical issue here, the pain will cause agitation. The agitation will cause asynchronized with ventilator. So we have a chain. So you have to manage pain initially in ICU. The first step to manage pain, if you want to sedate, to decrease the sedation, and you want to have patient comply with ventilator. So the pain is very important. It may cause short and long-term negative sequelae, and we are trying to manage with opioids in the ICU. The primary agents are opioids. Usually, we are deciding that this patient needs pain control or not by some scores or scales. We have behavioral pain scale in our ICU, and there's another one, critical care pain observation tool, but we are not using. The nurse will tell you this, the patient with pain control or the pain is controlled or not. Of course, the drug of choice, as I mentioned, IV opioid. There's other agents we may use for acetaminophen, like acetaminophen, or we have sometimes we are using carbamazepine for neurogenic or neuropathy, neuropain, and Brisidix we are using sometimes to reduce the pain. So we have many other indications we can use, but mainly IV opioid is the drug of choice, and those are adjunctive therapy. For non-pharmacological, we are trying to do some relaxation and pre-procedural pain control. This will cause dose reduction of IV opioids. The drug of choice of those opioids are fentanyl. Fentanyl is the most commonly used in US and here in Saudi Arabia. There is some advantages and disadvantages, but mainly it's safe and the drug of choice for our use for pain control. Usually we are starting fentanyl, the first agent, then we can start any agitation agent like midazolam or propofol or any sedation agent. The most commonly used, as I mentioned, the very quick onset of action and short duration of action, lack of pharmacological active metabolites. Fentanyl batch is not generally appropriate for use in ICU because there is some hypoperfusion, and the onset of action will be 12 hours. So usually we are not using fentanyl batch. Adverse effect, respiratory depression, bradycardia, hypotension. Bradycardia, the most important. Sometimes we will have hypotension, but not severe hypotension. Of course, as all opioids may cause ileus and constipation, we are giving some prokinetic therapy with fentanyl usually. For morphine, we are not using anymore. Morphine has many side effects because of the active metabolites. We have two active metabolites, morphine 3, which has no effect as a painkiller, but it's seizure. There's seizure activity and agitation, so the side effect is more than the effect. So we are not using morphine unless we have contraindication of fentanyl or uncontrolled patient with fentanyl. For the continuous morphine infusion are rarely used for analgesia in the ICU setting because of the concern, as I mentioned, with the active metabolite and the histamine release. Histamine release will cause hypotension and bradycardia. Remifentanil, a very good agent, but unfortunately we don't have it here. So maybe with time it will come, but there's a very good advantages that the clearance by blood and tissue, not from any organ. So if we have renal impairment, liver impairment, hepatic impairment, you will not be worried and you can give remifentanil safely. So non-opioid adjunctive therapy, as I mentioned, acetaminophen, sometimes NSAIDs, ketamine, neuropathic pain like gabapentin, carbamazepine. Okay, I think the slides of the propofol, there is some slides not there. But I will go through very fast. This is regarding the pain. About the agitation. Agitation, we are controlling agitation with sedative therapy. We have 4 options: lorazepam, midazolam, those agents, and benzodiazepines, and we have propofol and dexmedetomidine, which is the Brisidix. So for midazolam and lorazepam, we prefer midazolam, of course, because it's intermediate action, and the duration of action is intermediate, and lorazepam has a higher duration of action. Of course, with sedation, it's better or best agent. When you will discontinue, you will have end of the action. So we need no prolongation of therapy. So lorazepam we are not using. Also, there is the problem of propylene glycol. With lorazepam, the accumulation may cause toxicity, and usually we are not using any more lorazepam except if there is shortage with midazolam. For midazolam, better action. Of course, it's working on GABA, and the effect is dose dependent. We can reach a coma with midazolam, or very severe sedation, or very deep sedation, sorry, and we can have some mild sedation with the small doses. But usually with the prolonged use, it may accumulate also, and we will have some delay with weaning. Also, we have another issue for those with hepatic and renal impairment. It may accumulate faster, and you will have more or deeper effect. The last issue with the midazolam and lorazepam, the delirium. They found that using more lorazepam and midazolam may cause more delirium, or may in the ICU you will have higher delirium issue. So we are now trying to move from those benzodiazepines with deep sedation to the light sedation and non-benzodiazepines agents. Non-benzodiazepines like propofol. Propofol is the agent we are using for deep sedation and a shorter duration, and not benzodiazepine. It will not cause delirium. The side effect is limited. Usually we are worrying about hypotension only, and sometimes bradycardia. There is a very rare, very rare something called propofol infusion syndrome. I think we should not mention about, because it's very rare, and it will come with very high doses of propofol. Usually we are not seeing this. I think within 10 years we saw it 3 times. Unfortunately, it's fatal, by the way, but only 3 times before. Within 10 years we saw this issue. So propofol is the preferred agent for deep sedation. As I mentioned, fentanyl is the preferred agent for pain. For those patients, we should divide with sedation. You need deep sedation or light sedation. If you need deep sedation, you can use propofol or midazolam. We are preferring to use non-benzodiazepine, so propofol is preferred. For light sedation, if you want it for a few days, you will use a small dose of propofol. But if you want it for 1 day, we are using Presidex, which is dextromethylmethane. Dextromethylmethane has advantages like anti-inflammatory and analgesic effect. Also, it will not inhibit the respiratory center in the brain, so you can give it and extubate the patient, and it will has anti-delirious effect, so the patient will keep calm while he's on sedation, which is the dextromethylmethane. And here I will finish my lecture. Yes, any questions?
Thank you, Dr. Bashir. Please, if anyone has a question, they can write in the chat room, or they can raise the hand. So it seems there is no questions. Thank you, Dr. Bashir. Now we'll move to Dr. Mohammed Al-Udat.
Thank you very much. Salam.
Dr. Udat.
السلام عليكم. Dr. Ahmed, you can hear me?
Yes, yeah, boss, we can hear you.
يا سلام عليك. طيب.
Before Udat, excuse me. السلام عليكم جميعا. Before we'll go to Udat, I just want to يعني give all of you some about Dr. Bashir, a very, very good lecture. Thank you, Dr. Bashir, so much. But don't worry, it is just refreshing for your memories about the pharmacology of the most common drugs you can use while you are in the front line of the COVID. The point I want to highlight, we have protocols for everything, for the medication, for everything, and the ICU. Yani, for example, even antiviral, antibiotics, anticoagulations, with monitoring. Dr. Bashir also is the owner of this protocol for COVID-19. We have a specific detailed protocol, so don't worry, no need to bother yourself a lot. Just this is a refreshment for your memory, all of you. And the second one, even for the vasopressors, for the septic shock protocol, for the sedation, for analgesia, we have a specific special protocols, and the nurse can drive the protocol very smoothly. But just we want from you to know what the drugs you are using, what the type of the drugs, like that. So don't worry about the extensive pharmacology informations. It will be easy when you are in ICU to implement it. Thank you so much. Dr. Muhammad Audad, our ICU consultant, and his area of interest is acute kidney injury with the CRRT. I hope you will enjoy his lectures. It is.
Good evening. Good evening. Because acute kidney injury is a very important complication of the COVID-19, I will start my presentation with the definition of the acute kidney injury. Actually, there is no definitive definition of the acute kidney injury, but there is a several criteria, several different criteria to in the literature to define the acute kidney injury, like Life criteria, acute kidney injury network, the kidney disease improving global outcomes. And this is this first slide, the acute kidney injury. This is the criteria according to the kidney disease improving global outcomes criteria. And this is three criteria. And this is the most recent and most commonly used criteria to define the acute kidney injury. The acute kidney injury criteria present, if any of this criteria presented, we can diagnose a patient as acute kidney injury. First criteria, it's an increase in serum creatinine by 0.3 milligram per deciliter, 26.4 micromillimole per liter within 48 hours. Or if the increase in the serum creatinine to 1.5 times or more than within 7 days, or the urine output less than 0.5 ml per kg per hour for at least 6 hours. And this three criteria is the most recent and most commonly used the definition of the acute kidney injury. Next slide. The incidence of the acute kidney injury, it's a common disease. 7% of the hospitalized patients will develop acute kidney injury. From them, 30% of the patients admission to the ICU can develop acute kidney injury, and this is big number. So if the 100 patients will admit to the ICU, 30 patients will develop acute kidney injury. 15% of these patients will need continuous renal replacement therapy. And the acute kidney injury incidence of the acute kidney injury with COVID-19 still unclear. But there is a lot of study and going on nowadays, and the incidence reached 23%. There is 3%, 9%, a lot of study nowadays, but still the incidence of the acute kidney injury in the COVID-19 still unclear. But it's a common, I think will increase this number will increase. The incidence will increase in the acute kidney injury in the COVID-19. Next, the etiology of the acute kidney injury in general is a pre-renal, renal, and post-renal. And the pre-renal, most likely the COVID-19 will be in the pre-renal, because the patients with COVID-19 will develop multi-organ failure and sepsis. So the pre-renal azotemia leads to ATM, acute tubular necrosis. So will be pre-renal reach to the renal. Small number of the patients will develop the rhabdomyolysis because of the COVID-19. A lot of the drugs we will use also will affect the kidney and can increase the causes to injuries, the insult of the kidney, and the patients with COVID-19 will develop acute kidney injury. The acute kidney injury before was renal as acute renal failure. So this the pre-renal and renal will be in the COVID-19. Now we will discuss two cases. Put the case. First case. We have a case. This patient was admitted to our hospital. Then we referred him to the COVID-19 center. This 65 years old male patient. He is a known case of diabetes and hypertension. Is all CVA. Presented to the emergency room with the chiefly complaint cough and fever. And because of the nowadays any patient coming to the ER with these symptoms, patient immediately isolated in the isolation room, and they sent for him COVID-19 and came positive. We did for him X-ray, and we found bilateral infiltration. Put the X-ray. If you see the X-ray, this is the most common findings in the X-ray in the COVID-19, which is bilateral infiltration. Usually in the peripheral infiltration. This is the X-ray of the patients. And today we admit another patient with same X-ray. So this is the typical chest X-ray findings for patients with COVID-19. Next. This patient, we examined him. He is conscious, oriented, but little bit tachypneic. Respiratory rate was 30. Hypotensive, febrile. Temperature was 38.5. Blood pressure was 80/40 with MAP 56. And we saw him by the ICU team. We intubate him, connected to mechanical ventilation. And because of the ICU, usually we are monitoring the urine output. And according to our criteria, if you remember the criteria, his urine output was 20 ml per kg. So this is less than 0.5 ml per kg. So patient diagnosed as acute kidney injury according to our criteria. Creatinine was 350, urea was 25, and this was previously normal. So this increase in the creatinine. So this is another criteria. So this patient's diagnosed as acute kidney injury. So the diagnosis was viral pneumonia, acute respiratory distress syndrome, septic shock, and acute kidney injury. What's the cause of the acute kidney injury in these patients? Most likely this is because of the hypoperfusion of the kidney and septic shock. So the cause of the acute kidney injury of these patients was the hypoperfusion of the kidney and sepsis. Of course, the management of our goal of management of the acute kidney injury, it's ICU monitoring 24 hours. We are monitoring for 24 hours. This patient was inserted for him central line, of course. Urine output 24 hours monitoring in the ICU. The arterial line to monitor his blood pressure 24 hours. all the ICU, of course, management of the ICU. In the ICU, of course, there is a specific treatment and general treatments, and this patient receive all the monitoring and treatment of the ICU management. Of course, we give these patients adequate hydration, IV fluids, and we avoid the nephrotoxic drugs. We monitor the labs, of course, the ABG, VBG, of course, his lactate and CPK, ferritin, and D-dimer, LDH, all this criteria of the COVID and the severity of the COVID patients. All these labs we are monitoring. Then these patients, after that, dialyzed with the CRRT, continuous renal replacement therapy. And we chose for these patients for the CRRT, the CVHDF with cytosorb filter. The CVHDF, this is the continuous venous hemodiafiltration. And in this mode, we are using all the mechanism of dialysis, which is diffusion, convection, adsorption, ultrafiltration. And the cytosorb, we are removing all the cytokine pro-inflammatory mediators like interleukin 1, interleukin 6, and all this pro-inflammatory cytokines, which is they are believed this a cause of the multi-organ failure and acute kidney injury. So the cytosorb, and there is a study with 70 patients with the they use with the cytosorb, and there is good result of the cytosorb filter and cytokine remove. So the mode of choice with patients with COVID-19 and acute kidney injury will be CVHDF, because that the CRRT, there is 4 modes, which is SCUF. This only we are using for the patients to remove the fluids. CVHD, this like intermittent dialysis, and CVH to remove the large molecules. But the CVHDF we are using for the septic shock with cytokine storm, like in patients with COVID-19 with acute kidney injury. Next. This is our case. The another case is not a COVID. This patient, his name is Muhammad. He's 45 years old, admitted to the ER after the RTA with massive abdominal trauma with fractured femur, taken to the OR for bowel perforation and liver laceration. He received 4 units backed RBCs, and the 5th unit was stopped in the ICU because of the transfusion reaction. On the day after the surgery, his urine output decreased to 10 to 20 ml per hour, which is according to our criteria, this patient developed acute kidney injury. We increased the fluid intake, but doesn't improve his urine volume. And the lab showed the increase in the urine sodium. Urea was 20, creatinine was 400. So this patient, according to our criteria, developed acute kidney injury. On the 3rd day, his urine output was 25 ml per kg. So a patient diagnosed as acute kidney injury. Because of the persistent hyperkalemia, patient started in hemodialysis. And his CPK was high. What's the cause of the acute kidney injury Muhammad develops? Most likely this patient was because of the, you can put the question, next. What the cause of the acute kidney injury Muhammad develops? Because of the trauma, most likely this is rhabdomyolysis with persistent hyperkalemia, because of the transfusion reaction, because of the hypovolemia, toxicity of the liver. So this patient developed acute kidney injury. What the clinical indicators Muhammad has in oliguric phase of the acute kidney injury? Because of the decreased urine output, less than 30 ml per hour, so we diagnose him as acute kidney injury. Next. we have to give attention of these patients. Of course, because of the rhabdomyolysis, because of the persistent hyperkalemia, increased secretion, fluid overload. Usually, we are resuscitating the patients with a lot of fluids. Maybe the patients will develop overload. So we'll try with them. If the patients develop the overload, we will try diuretics. But usually, the diuretics is not a treatment of the acute kidney injury. So alternated also tissue perfusion because of the high risk of the bleeding. So we have to concentrate in this etiology and to avoid the complication of acute kidney injury. What's our goal for management of these patients? Usually our goal, the ICU monitoring, adequate hydration. Of course, because of this patient's blood, you have to replace the blood if needed. You have to prevent the infection, monitoring the labs frequently, and to avoid the nephrotoxic drugs. So what is the usual indication for dialysis in acute kidney injury in general? And on both patients was indication from this indication. The indication for renal replacement therapy, if the patient's anuric or oliguric urine output less than 200 ml per within 24 hours, within 12 hours, this patient usually needs the dialysis with the CRRT. And this is very important to monitor the urine output hourly in the ICU. And if this patient needs dialysis, you have to start as soon as possible dialysis for him. Of course, persistent hyperkalemia, if the patient not responding to the medical treatment of the hyperkalemia and the potassium more than 6.5 ml per kg, these patients usually need CRRT dialysis, CRRT or intermittent dialysis. But in the ICU, we are using, because the patient unstable, we are dialysing the patient's bedside with the machine of the CRRT, which is continuous renal replacement therapy. If the patient develops severe acidemia, the pH less than 7.1, persistent, not responding to treatment, not responding to the IV fluid, so these patients will be dialyzed. Azotemia, urea more than 300 with clinical significant organ edema, and especially the lung, pulmonary edema. So if the patient developed uremic encephalopathy, uremic pericarditis, uremic neuropathy, uremic myopathy, all this indication, uremic symptoms indicated to the patient to be dialyzed. The drug overdose, usually we are treating the patients with the CRRT to remove the drugs. Also, there is an indication if there is a persistent hyperthermia, you can use the CRRT to decrease the temperature of the patients. Next. So this Mohammed, we sent for him CKA, and we found that CKA 40,000. This is a big number. So which mode of the dialysis will be the mode of choice? What do you think? You can write the answer. Of course, this patient we will do for him CVH. CVH is we will use only the convection because of the rhabdomyolysis. You can use the CVH without CVHDF. But if the patients develop septic shock, better to do the CVHDF. But the CVH, it's enough for this patient to remove the myoglobulins, which the indication here for dialysis, the rhabdomyolysis, because of the CK very high. So the CVH is the mode of choice. If you will do CVHDF, it's not wrong, but it's more expensive without benefits. If you will choose CVH, it's enough for the patients with rhabdomyolysis. Next. Of course, the CVH is continuous venous hemofiltration. Next. Because of the contrast-induced acute kidney injury, it's a common in the ICU. So we have to know the risk factors of the patients will develop acute kidney injury due to contrast. So the risk factors of the GFR less than 35 ml per minute. If the patient diabetic with diabetic nephropathy, severe congestive heart failure, large volume of the contrast, and pre-existing hypotension and hypokalemia. So any patient you will send for investigation, he will receive contrast. You have to treat or avoid these risk factors. If the patient hypotension, you have to resuscitate with IV fluids, with inotropic support. If he's hypokalemic, you have to replace the potassium. If this investigation unnecessary, you have to avoid this investigation because the patient will develop acute kidney injury due to contrast. Of course, the prevention of the contrast-induced acute kidney injury, it's very important. This is the crystalloid, which is 1 to 1.5 ml per kg per hour for 8 to 12 hours before the procedure. And this is the safest and most effective prevention of the acute kidney injury due to contrast, and contrast-induced acute kidney injury. The other prevention, you can use an acetylcysteine, 2 doses, 600 milligram doses, but this is controversy, and the type of the contrast. The type of contrast is very important to avoid the acute kidney injury. The management, of course, the goal to avoid and to correct the reversible causes of the acute kidney injury is very important, because if you will prevent the acute kidney injury, the mortality will decrease. Because any patients will develop in the ICU acute kidney injury, the mortality will increase 28 to 30%, the mortality. And still the cornerstone of the management of patients with severe acute kidney injury is a renal replacement therapy. Still, the renal replacement therapy is a cornerstone of management with severe acute kidney injury. Of course, in the previous SARS and MERS corona infection, the acute kidney injury was 5 to 15%, and the mortality was very high with patients with MERS, was 60 to 90% the mortality rates. So in the COVID-19, we suspect the mortality will be very high with acute kidney injury. And the early reports will suggest a low incidence of the 30% to 90% of the acute kidney injury with COVID infection until now. But the study going on, and there is a study now, there is with 23% patients with COVID developed acute kidney injury, and the mortality very high with these patients. So we have to interfere and to manage the patient as soon as possible with COVID-19 with acute kidney injury. What about the treatment in the COVID-19 with acute kidney injury? Still the same. This is a general and supportive treatment with renal replacement therapy. Still the same. Of course, you have to take all the precaution when you insert the line with PPE, but the principles of the dialysis, all these issues with acute kidney injury, the same like any patients in the ICU developed acute kidney injury. Thank you. And if you have any question, I will be happy to answer it about the acute kidney injury. Any question? Dr. Ahmed? Dr. Ahmed?
Just we are waiting the question if there is any
question.
Okay,
yalla. Okay. Yes. Of course, our patients, I will tell you about our patients. Alhamdulillah, this patient we did for him plasmapheresis. Alhamdulillah, he is extubated now. We're transferred from the ICU.
So there is a question, what is kidney replacement therapy?
What is?
The kidney replacement therapy.
Kidney replacement therapy?
Yeah.
This is the CRT. We are replacing the function of the kidney. And the CRRT, this is continuous renal replacement therapy. Usually the dialysis, there is a type of the dialysis. There is intermittent dialysis, peritoneal dialysis, and continuous renal replacement therapy, and SLIT. In the ICU, we are using as replacement therapy the CRRT. This is a continuous renal replacement therapy with a portable machine, and the principles of the dialysis is the same. But we are using for the patient unstable because of the flow, it's low. So we are using the continuous renal replacement therapy in the ICU. This is like intermittent dialysis, but the same principles, but we are using in the patient unstable. We are replacing the kidney function. Yani if the patient needs to remove the fluids, we will remove electrolytes. We will correct the electrolytes. We will remove the toxins from the patients, and we will correct the buffer system. This is the replacement therapy. We are replacing the kidney function.
Okay, there is another question. Regarding the COVID-19, what is the HDF?
COVID-19, COVID-19, the mode of choice.
Yeah, what's the mode of choice? They are asking.
Usually COVID-19, the patients will develop ARDS with multi-organ failure and acute kidney injury with septic shock and sepsis. So that they believe the cytokine storm induced systemic inflammatory response. So the drug of choice in these patients will be the CVHDF to use the convection to remove all the cytokines and pro-inflammatory mediators. So we prefer to do CVHDF with cytosol. This will remove all the cytokines and will help the kidney, because usually the acute kidney injury is reversible cause. If we will help the kidney and we will remove all these cytokines, the kidney will work again, and the function of the kidney will reversible cause. So that the mode of choice will be the CVHDF with all mechanism of the dialysis.
Okay, there is another question. They are asking, what do you recommend? Sorry, they are asking how we can. It's preferred to do the dialysis in COVID-19 patients immediately or refractory.
So this is controversy. There is controversy. Until now, the indication for dialysis, we mentioned the dialysis. The patients develop the persistent hyperkalemia. If you have to dialyze the patient according to this indication. But early and late, still the same result. Same result. The late and the indication, of course, as any acute kidney injury with the complication. Uremic encephalopathy, patients with anuric, he's not making urine, so this is the indication in the COVID. Still same indication.
Okay, there is another question. What book you are recommending to read from basic CRRT?
مش سامع أحمد إيش السؤال؟
What's the reference you are preferring to read the basic of CRRT? As reference.
To read?
Yeah. Do you ask from where they can read the basics?
Give them my lecture. Enough.
Okay.
My lecture will very easy. and they can see all the mode, how to use the CRRT, what's the mechanism. Give them all these lectures of the CRRT. It's easy to read, and it's not too much written there. We remove, and it's simple. You can read and you can understand what's going on with the CRRT.
There is another question actually. They are asking how much the reversibility of renal failure after CRRT in acute kidney injury.
ما فهمتش السؤال ده يا أحمد.
يعني if the patient has renal failure,
okay,
what is the reversibility to back to baseline or to recover from acute kidney injury?
In general, or in the COVID? In the COVID until now, nobody knows. يعني still this is new, but in the general, up to 30% of the patients can reverse. According to the, if there is if this is acute kidney injury, acute kidney injury without another multifactorial. If there is multifactorial of the acute kidney injury, the reversible, only 10% of the patient will reverse. But if there is only one cause, it's high, up to 30 to 40%.
Okay,
the kidney will revere, and the patient will, like for example, rhabdomyolysis. Rhabdomyolysis, the patients up to 70 to 80%, the patients will reverse in rhabdomyolysis if you will remove all the myoglobulins, and the kidney will reverse. So this is according to the cause why the patients developed acute kidney injury, and if the or multifactorial or multi insult of the kidney, drugs or infection, hypoperfusion of the kidney, all this will play a role for reversible. But usually 30 to 40% if one risk factor.
Thank you so much, Dr. Odat.
I have a question for you, Dr. Odat. Thank you so much. I want to ask you if you have a criteria for dialysis for such patient, any patient, right? And the same criteria for the same patient but was with COVID.
Right.
So your decision to dialyze would be different based on COVID only? The same criteria for both patients, one with COVID, one without COVID?
No. With COVID, so I preferred early dialysis with cytosorb. If the patient is not overloaded, you can do without ultrafiltration. Better to remove and help the kidney before the patients will develop all this complication. So we did for one patient with COVID in Abdurrahman Al Faisal. Patient was no any indication for dialysis, but we did for him dialysis without ultrafiltration with Xeris filter, cytosorb, and the patient improved. Urea with creatinine improving, and urine output improve, and kidney function improve after 2 sessions of dialysis. So I prefer to dialyze the patients if the patient not overload. You can do without ultrafiltration, and to help the kidney and to remove all this cytokines and urea, creatinine, all the pro-inflammatory mediators. You can do 1 session, 2 sessions, and I preferred early dialysis in the COVID patients.
Thank you, Dr. Odat, so much.
Thank you. Please, thank you, Ahmed.
So we have Dr. Balch is waiting. طيب.
يلا سلام.
Welcome, Dr. Muhammad. يا هلا فيك.
حبيبي سلام.
سلام. Yes.
Thank you all. I'd like actually to present one of our active consultant with us, actually, Dr. Ahmed Al-Balchi. He will talk about COVID pneumonia. It is a very extensive and the practical lecture, I think. And you will find it in every COVID patients. Every slide of his lectures, sure, it will be implemented in every COVID patient. Welcome, Dr. Ahmed.
Welcome, Dr. Madi. I would like Let me share the screen. Yes. Why is not sharing? Yes. First, I would like to thank the organizing committee for this course, and especially Dr. Ahmed Madi, Dr. Gultakin, Dr. Ahmed Kuhail, and for giving me this privilege to be here in the course and presenting the topic of pneumonia in COVID patients. First, I will put this slide about the coronavirus numbers until now in the world, until today, April 22 seconds, 2020, we have around total cases of 2,600,000 cases with death about 180,000 and recovering are about 700,000 cases. In Saudi Arabia, until today, we have 12,772 cases with the death around 114, with total recovered patient about 1,812. Why you put these numbers? Really, we need all to know that this is really a pandemic. It's a huge number. It will affect more and more. Still, the COVID pandemic will not finish soon, and I am sure we will have more than this number or double this number, because some countries are not reporting correct numbers of the cases, and some countries are socioeconomic low and doesn't have the screening test or the PCR, and that's why I think still we will have a lot of these numbers, more than these numbers what we have. And as a physicians, we should know, all physicians, even in all specialty, they should know about the pandemic in the world, and I am sure they will face one time patients with COVID, and they have to take their precautions and protect themselves and their family. Coronavirus, as we know, it's called COVID-19. Why we are calling sometimes COVID-19 and why we are calling SARS-CoV-2? COVID-19 means, when you are talking about COVID-19, we are talking about the disease itself. But when we are talking about SARS-CoV-2, is the virus name. That's why COVID-19 is caused by the virus which called SARS-CoV-2. As we know, the pandemic started in China and Wuhan in the late of 2019, and the seafood animal markets, and that China are believed that this is the center of the outbreak. Pneumonia in COVID is resembling the other viral infection, and the severity of illness depends on the older age and presence of underlying other conditions. Put in your mind that asymptomatic patients, which is around us, could be everywhere, are found to have similar viral load comparison with the patient who are symptomatic. That's why we have to take care when we are going to markets, going out of home, with not contacting with other persons who are sick. Most children present with mild symptoms, but with sometimes even without fever or pneumonia. About 80% of people recovered from this disease without needing any special treatment. That's why I'm telling the number is not correct, because a lot of people are asymptomatic or they have a mild symptoms and they are not presenting to any clinic or other hospitals. What about transmission? It's proved now it's a droplet transmission. How it comes, it could be direct or indirect. Direct, when the patient who is infected is coughing front of you with direct contact, and you are inhalation this viruses. Indirect contact or infection, when the infected person who is coughing or sneezing on the other surfaces, and you touch by your hands these surfaces, and then you touch your eye or nose or mouth. That's why your hands cleaning of your hands is very important to protect yourself from getting this infection. Droplet are a little bit heavier than airborne. That's why it's not transferring more than 2 feet, 6 feet, about 2 meters, and the not liner in the air. But in special situation, in the healthcare workers, when we are doing a procedure which can generate aerosol, we should take care, and airborne precaution are recommended. What about pathophysiology? I think pathophysiology will explained and touched by our colleague, Dr. Waqas, but just as refreshment and quick review, the virus will enter the cells through the AC2 receptors. Then it will start the response for this virus, immune release, and cytokines, chemokines, which lead to uncontrolled systemic inflammatory response, which called cytokine storm. This is about pathophysiology. The slide, as we say before, the virus will enter the lungs, epithelium, through the AC2 receptors, then start the replications, and or will continue the replication. Then the cascade of inflammation will start, and the cellular immunity activated. A lot of cytokines will release, interleukins 8, 6, but mainly interleukin 6, which can make direct damage to the lung. Dr. Gattanoni is the German anesthesiologist. He changed the practice of our management of the COVID-19 patient when he discovered the pathophysiology of the disease. He and his colleagues, they report about on 150 patients, and they found more than half of these patients has near normal respiratory system, despite having severe hypoxemia. Analyzing from these cases, that determined that there was a different patterns of COVID-19 patients. It's not one patterns what we are thinking before, which is like ARDS-like syndrome. No, and these patterns are depending on the interaction of 3 factors. Factor number 1, the severity of the infection, the host response, and the physiological comorbidities. The second interaction or second cause is the ventilatory responsiveness to the hypoxemia, and the third is the length of time between symptoms onset and presenting to the hospital. Gattanoni and his colleagues say that the consideration of these factors leads to the view that there are 2 types of COVID-19 patient, and they call it phenotypes L and phenotype H. Here, I will try to explain what is going on. Initially, we will have the low VQ, ventilation perfusion ratio. Vasodilatation will happen in the pulmonary vasculature, and pulmonary vasoplasia, which leading to hypoxemia. Also, we have the stimulation of the respiratory drive in the brain, which is also adding to increase the work of the breathing. This low ventilation perfusion, which called low phenotypes, this is the initial stage of patient who have the COVID, and more than 50% of the patient will be in this stage. But with time, this stage can be converted to another stage, which is called high VQ or very low VQ, when we'll have the more cytokines, more inflammation, and perfusion will be okay, but ventilation will be low. In the first stage, in the low VQ, we will have good perfusion and ventilation. Later on, we will have low ventilation. Here, what is meaning by phenotypes? Phenotype L mean that we have a low elastance, means low elastance. This is the normal, which is called normal compliance. Low VQ perfusion ventilation scan ratio, and low lung weight, and low recruitability. Why low recruitability? Because we don't need recruitment. The lungs doesn't need recruitment at this stage, and that's why we don't need a higher beep. But in a very low VQ ratio, which is called phenotype H, we will have high elastance, low compliance, high right to left shunt, and the high lung weight because of the edema and the inflammation. And this at this stage, lungs need recruitments, which is called higher recruitability, means we have lungs needs recruitments. That's why we will go with the higher beep. In the middle, we will find that sepsis induced coagulopathy, and this stage we will have a higher high of the markers levels like D-dimer, fibrinogen, BT and BTT, and sometimes low platelets. And in this stage, we will have the micro or macro thrombosis in the lung. And CT scan here, and this is from patients of Gattanoni, Dr. Gattanoni, we will find that in phenotype L, low, we will find the CT scan, which is having peripheral ground glass opacity, which is not severe here. Then, but if we will go to the phenotype L, see how is the difference between CT scan between phenotype L and phenotype H. Here we will have here more consolidations and ground glass appearance and more shunt fraction. If we will go to the clinical features of the COVID-19, as we know, the incubation period is around 14 days, and the illness severity is different between mild to severe to critical. Mild cases reported, as we say, in 81%, severe cases in around 14%, and critical diseases around 5%. We define the severe diseases when the patient have hypoxemia, severe hypoxemia, or more than 50% lung involvement in the imaging within 24 to 48 hours. But put on your minds that patients with mild disease can go to the next level, which is severe disease. Then the severe diseases can go to the critical. 10 to 15% who having moderate or mild moderate disease will convert it to the severe, and 15 to 20% of the critical patient, of the severe patient, will go to the critical stage. What about virus shedding? Virus shedding was highest early in the course of the disease and can occur in the 24 to 48 hours prior to the symptoms. Virus shedding is usually continued 7 to 12 days in the mild moderate diseases, but for more than 2 weeks in severe cases. Patients who recovered from the disease can still have a PCR positive after the symptoms resolve. Now, how we can differentiate between bacterial and viral pneumonia? Clinically, patient will come to you in your clinic and you want to know, is this patient really having the COVID, viral infection, viral pneumonia, or bacterial pneumonia? Actually, to be honest, it's difficult to distinguish clinically between both, but there is some points that can help you, which is the history. Like in COVID viral pneumonia, most likely the patient will give you a history of contacting with the sick patient or with positive COVID patients. They will have severe muscular pain, myalgia, and there is a symptoms recently we noticed or observed in COVID patients, which lose of the sense of smell or taste. Patient will come breathless, but has no pleuritic pain. This is very important. And as we say, they have history of exposure to another or suspected cases of COVID-19. But if bacterial pneumonia, more likely the patient will come with productive cough, no history of contacting with patient suspected COVID or confirmed COVID. Patient will not have pleuritic pain. Patient will have pleuritic pains, and this is that can differentiate between both clinically, but it's not pathognomic for that. And the symptoms when bacterial pneumonia will be more fast with a few days, and patient looks unwell. What about the presentation of the viral pneumonia, especially COVID patients? It's non-specific, as we say, but the common symptoms is a fever, which is account around 85 to 90% of the patients, dry cough, and fatigue, myalgia. As we know, the GI symptoms is very rare. Can patient come with nausea, vomiting, and diarrhea? And don't forget the symptoms, which is loss of the sense of smell or taste. I think this slide to just explain the stages of the patient with COVID, and it will explain and discussed by Dr. Ahmed Madi in his lectures, but just will show that patients can come with pneumonia, with hypoxemia, or without hypoxemia. Can patient have chest X-ray findings and pneumonia, but he is not hypoxic? And the opposite is there, right? Also, patient can have normal chest X-ray, but with severe hypoxemia. In the last stage, when patient will become critically ill with shock and ARDS, at this stage, most likely the patient will be in ICU, and the mortality rate in the ICU for COVID patient is high, and it's around between 50 to 70%, approximately 60% of ICU patient is dying. What about the complications? As we know, pneumonia is the complication, acute respiratory distress syndrome, also cardiac injury. Patient can come with MI or arrhythmia or even cardiac arrest, cardiomyopathy. Secondary infection is common, sepsis, and acute kidney injury with multi-organ failure. In physical examination, there is no big difference between bacterial and viral pneumonia. You can hear respiratory crackles and bronchial breathing sometimes, and patient will be in respiratory distress, may have tachycardia, tachypnea, or cyanosis combined with hypoxemia. This question, just I will raise it here before starting the imaging discussion about the COVID. What is the most common findings in chest X-ray in COVID patients is bilateral lung infiltration. And it's correlate with the degree of hypoxemia. Is it true or false? I hope all will answer these questions. I will wait for the polling. Yes, good. Now around 22 of 50% of the participants are answered. Still 30 seconds. Is the chest X-ray findings are correlates with the degree of hypoxemia or no? Still 20 not answer the questions. Okay. 8 seconds remaining. Actually, what can I say? It's the answer was 53% for the true and 47% for the false. Okay, the correct answer is false. Yes, most common findings in the COVID patients is bilateral lung infiltrates. This part is right, true, but it does not correlate with the degree of hypoxemia. I mentioned it just a few minutes before. Patient can have a near normal chest X-ray, but is severely hypoxic. And the opposite is right. May we will have a horrible chest X-ray, but patient is not hypoxic. And the answer is false. Right. Now we'll move to the second part of the presentation about imaging. The imaging protocol depends of the hospital and institutions. But as usual and simple, chest X-ray is the first line modality in those patients. It's less sensitive than CT scan, and please, when you order chest X-ray, ask for portable chest X-ray, limit transportation of the patient to limit the transmission of the infection and healthcare worker exposure. Chest X-ray may be normal in early or mild disease, but in severe cases, you will have the unilateral lung infiltration like lobar pneumonia, and you could have bilateral lung infiltration. The most common is the bilateral lung infiltration, and mainly in the lower lobes and peripherally. It's found in 75% of the patients. And this is the chest X-ray of patient with intubated patient on mechanical ventilation. As we see here, there is bilateral lung infiltration, ATT, and central line, internal jugular central line. Right. Next imaging modality is point of care ultrasound focus. In China, initially they are putting the CT scan chest as mandatory and the first line imaging, but later on they start to use the ultrasound, lung ultrasound, and they found it is useful in the evaluation of critically ill COVID-19 patients. What we can see in ultrasound, we can see the following patterns: multiple P lines. I will explain what is P lines, and this is the most common findings. Irregular thickened pleural line with scattered discontinuation, subpleural consolidation also common, alveolar consolidation, and believe me, now the ultrasound or point of care ultrasound is the most important imaging modality we should concern and concentrate on it, because it can be done by the physician at bedside trained physician. We need trained physician to do this ultrasound, and it's easy and short and just point of care. It's not like the full lung ultrasound, which will be done by the radiologist, but it's enough for us to detect the consolidation. We can detect the pleural thickening. We can detect the pleural effusion, which is uncommon in COVID patients, but a lot of information can be detected by the ultrasound, and it will help us to not go for unneeded procedure or like CT scan, which is dangerous because of transferring patient outside his room and exposure to other healthcare workers and radiologists. This is the ultrasound photo we can see here. This white color, vertical white colors, is the B lines, called B lines. It's 3 B lines. And the black in between, this black is the ribs shadow. Here we can see the scattered and confluent P line. And also here we can see the consolidation, and the black, as we say, this is the rib. And there is this continuation of the pleura here, and there is large consolidation in the ultrasound. When you will use the ultrasound, you will use the probe, which is low frequency, which is the echo probe, which is better than the curved one. And let's see here, the A line. A line is different than P line. A line is the transverse lines, which is normal pattern in the ultrasound. And really, when we will see the A line, that's mean our patient is recovered. Here is the B lines. Here is B lines, which is reflect the patient having consolidation or pulmonary edema. Here, scattered B line also, as we see. And here we can find the consolidations, which is, there is dense particle inside, heavy lung, which called these consolidations. It's very helpful, and it correlates with findings on the CT scan. Here, what we found in the CT scan, we found there is a ground glass opacity, and same patient, same area, ultrasound lung showing 2 P lines, which is reflecting the ground glass opacity that's equal to P line. What about CT scan? A lot of debate between CT scan and ultrasound. Yesterday, there was a good lecture by our colleague, Dr. Salman, about the imaging modality, CT scan or ultrasound. It was optional in the course, but I hope all candidates are responding and reviewing this lecture. When we have to consider the CT scan, if I don't have any trained physician for ultrasound, if the chest X-ray is normal and still the PCR result is negative, and a patient not intubated, then I will go for CT scan. Also, when I have the patient who needs CT scan of other part of the body for other reasons, like trauma patient or patient have acute abdomen, I will go for CT scan. Better at the same time to request the CT scan chest. Or if I want to exclude BE in patient who was unexplained hypoxemia, then I will go for CT scan. But the good with CT scan that the positive findings in the CT scan may precede the development of the symptoms even prior to the detection of the positive real-time PCR in COVID patient, and which can help in the making decision in early stages of the patients. CT scan, as we say, it was the primary imaging modality in China. For those who doesn't know the CT scan findings, how can read the CT scan, just quick review. This is called nodular lesions, and this is the ground glass opacity. See different color gray colors, and this called cavitation. And here we will have the pleural effusion. This is the pleural effusion. And this is the consolidation with air bronchogram inside. This is just to show you how is different the lesion in the CT scan when you don't have the report and you want to read the CT scan. Right. What are the common findings in COVID patient in the CT scan? We have ground glass opacity. This is the most common findings. Crazy paving appearance, air space consolidation, bronchovascular thickening, and traction bronchiectasis. Pleural effusion and lymphadenopathy is very rare or called atypical findings on the CT on COVID patient. As we say, please avoid unnecessary exposure and don't do it as routine. This is the CT scan of patient with COVID. See how peripheral ground glass appearance and consolidation in the lungs everywhere, bilateral. Right. We'll move to the next step of patients with COVID about molecular testing. Molecular testing is required to confirm the diagnosis. And even the screening now, the active screening, which is done in Kingdom of Saudi Arabia now, it depends on the molecular testing. We are discovering the genetics of the RNA, the genetics of the virus itself, which is called PCR, real-time PCR. How we can take it, the sample, we will use the respiratory tract specimen, nasopharyngeal aspirate, or oropharyngeal nasopharyngeal combined with oropharyngeal swabs, both together. We will see why both together. If the patient is spontaneously breathing, but if the patient is already intubated and I have negative sample which was taken before intubation, then I will go for the blind suction of the sputum from the ATT, endotracheal aspirate, or bronchoalveolar lavage when it's possible in intubated patients. Right. Next, the questions. What's the highest rate of the positive real-time PCR in the COVID patients? And the issue behind this question, just we want to know what is the best for approaching patients with the COVID-19, what's the best sample to be taking and why? Yes, pooling is there. Still half a minute. Yes. We can end the polling here or still? Yes, 83% they answer bronchoalveolar fluid BAL and 17% for nasopharyngeal swab. Okay. We'll stop here. Right. The highest rate is for BAL. I think it's touched in other lecture before with Dr. Madi. Yes, 93% for BAL and 72% for the sputum. For nasopharyngeal swab, it's 63%, and pharyngeal swab, oropharyngeal swab is 32%. Means 2/3, the nasal swab can detect 2/3 of the cases, and pharyngeal swab can detect 1/3 of the cases. If I combine both together, then I will reach with higher positivity and sensitivity. If the initial test is negative and patient still strongly suspected to have COVID, please recorrect the sample again from the nasal and from oral both together. But if your patient is intubated and having negative result or not taken yet of the test from nasopharyngeal, please go for sputum from the ETT. Then what is the recommendation based on that? Don't order, please, sputum induction, because in a spontaneous breathing patient, when you're ordering him to coughing and giving you sputum sample, he will spread the infection for the healthcare workers. Avoid bronchoscopy unless absolutely indicated. A pulmonary function test or spirometry are not indicated. Airport precaution for aerosol procedures like intubation, extubation, PAL, and bronchoscopy. If healthcare worker failed the N95 test, fit test, he should go for the next step, which is powered air buffering respirator or controlled air buffering respirators. What about the rapid test? All we heard about the rapid test. Rapid test was done from the blood, but the molecular testing is done from any other samples, as we know, from the nasal secretion, from the oral, from the sputum. Regarding rapid test, which is available now in our hospital, we can see here in the left side of the screen, this is the test, and we can see CGM. C mean control, and G, IgG, and M, IgM, which detecting the antibodies. When you have red color on C only, means this is the control. After you put the buffering solution, you will find red color coming here, means the test is okay, can be used. Here we can, very important slides that we see this, which called window period, with patient is asymptomatic or start the onset of the symptoms, which is between 0 day to 7 days. Most likely patient will be asymptomatic or start to have a mild symptoms. We will find here we can detect the blue line is the PCR. Then at day of 14, start the PCR, patient start to be recovered and start to decline down until day 28. IgM will be detected from day 7. Then it will go up at day 14, the peak, and will be disappeared on day 21. IgM starting to raise or be positive from IgG from day 14 when patients start to recover until maybe few weeks, we don't know, months after the recovering from the disease. What is meaning? IgG means patient is having immunity, patient is recovered from disease. If you have all both together positive, as we will see, the interpretation of the test, how it will be, I will explain it very well next slide. But here, just please to know that don't do the rapid test in early of the disease or in asymptomatic patients because it will be negative. This is the interpretation of the rapid test. When you have PCR molecular positive with negative rapid test IgM and IgG, means patient may be in the window period of the infection. That's why we should not depend on the rapid test, especially initially of the disease. Patient may be asymptomatic or just starting to have a mild symptoms. When you have a positive PCR and positive IgM, this means patient in early stage of infection. When you have all positive, it means patient in the active phase of infection, maybe on day 10 to 14. when you have a PCR positive and negative IgM and positive IgJ, means patient in the late or recurrent stages of the infection. If you have only IgM positive, means patient in early stage of infection, but PCR may be false negative because maybe the way what was taking the sample is wrong. When you have IgJ only positive, means patient is recovered of the infection and he have a past infection before. When you have both IgM and IgG with negative PCR, patient may in recovery phase of the infection, or PCR may be false negative. This slide, if can I ask you, but I will just explain here. The test still not started yet. Not the solution for the COVID is putting here, and the control that is red line only. The control means the patient maybe doesn't have the disease, and or still we won't put the blood of the patients. Here, a patient have a control. It must be read to know the test is okay. This patient is in period of the infection. Here, the patient, this patient is recovered from infection because IgJ is positive only. When you have IgM patient in active phase of the infection, and these are both together, means patient on the late stage of the infection, but still not recovered yet. What about laboratory findings? I will go quickly. Please check CBC and differential in all patients as a routine. Liver function test, LDH, C-reactive protein. Leukopenia is common, found in 30 to 45%, and more common is lymphopenia. I saw it by myself. The lymphopenia around 5 of 7 patients in our hospital having lymphopenia less than 1,000. Thrombocytopenia is little bit rare, unless the patient in severe diseases and having DIC. Leukocytosis less than 5%, but it can be high when or present leukocytosis with patient having superimposed infection, bacterial, other infection with bacteria. High liver function test and high LDH, high C-reactive protein, high procalcitonin. Why we are doing these lab investigation? Because for prognostics and severity, prognosis and severity of the disease. Put in your mind that severe COVID-19 patients have high D-dimer and ferritin, and D-dimer is correlated with mortality, and found in the autopsy of patient with COVID, around 50% of the patient having non-survivor patient having high D-dimer, and most of them are in the admitted to the ICU. D-dimer is very important and correlated with mortality. Lymphopenia not correlated with the mortality. This is the prognosis, which the indicators which is indicate poor prognosis, and will I think explained before. But as you see here, D-dimer is one of the poor prognosis criteria or indicators, and the C-reactive protein more than 100, elevated troponin, especially patient will have cardiac injury here, lymphopenia, multiple comorbidities disease, especially diabetes and chronic kidney disease. When your patient having respiratory rate more than 24 or heart rate more than 125 beats per minute, or desatting less than 90%, this is important to know. Epidemiological and clinical and lab, if you put all both together, then you can decide that our expect patient we will deteriorate and worsening, and he needs a higher level of care. Here we can, this published in Lancet 2020, we about the relation between the D-dimer and non-survivors. We can see here that D-dimer is start to elevate on day 7 and is correlate with death. See, non-survival, but while the survivors patients from COVID doesn't have a higher than 5 or 0.5 of the D-dimer. Means when you have a D-dimers high, this indicates severity of the disease, and a patient can be expected to have worsening and death. There is some index, one index called the COVID Severity Index, which only predicts subsequent disease course. The lower COVID Severity Index in patient will have higher likelihood of survival, and lower COVID Severity Index in the patient is more likely to get off of the ventilator rapidly if you have the lower. This index or the severity index just predict the course of the disease later on. What is this severity index based on what? Based on neutrophilic lymphocytic neutrophil lymphocyte ratio, C-reactive protein, and D-dimer. And this is the equations. If you have the equations as the cut point is 5.3. If you have patients with index 0.25, then he can be saved. He will not deteriorate. He is can be treated as outpatient. If you have 5 to 20, that patient admitted to the ward. If more than 20, that patient is severe disease and should be in ICU. There is other sure about pneumonia in general. Pneumonia severity index, curve 65, quick SOFA or SOFA score, but it's not 100% applicable for COVID patients especially, and we cannot rely on it. Type. The recommendation for the pneumonia with hypoxic respiratory failure, that start please with oxygen, nasal cannula, or simple mask, or non-rebreather masks. Consider early intubation. Why early intubation? To avoid use of aerosol generating by non-invasive ventilation. Again, to avoid any emergency of the intubation, which carry the higher risk for exposure to the healthcare worker. Use rapid sequence intubation. Don't allow patient to cough. Avoid bag mask valve if possible due to risk of droplet spread. Avoid direct laryngoscope. Please use the video laryngoscope when it's possible and it's available in our hospital. Use lung protective ventilation strategy and try to put patient in the prone position early. Even some recommendations that patient, even he's not intubated, you can ask him to sleep on his abdomen. I know it's upsetting position, but it will help in the hypoxemia. ECMO is as a salvage only for patients who is having refractory hypoxemia while on the mechanical ventilation. This is the last slide. The questions to understand if you are willing to approach patients with the COVID. And this is the pooling. You have around 55 years old patient who is hypertensive on captopril, came back from Italy 1 week back and presented to your clinic with upsetting dry cough and fever, high fever, no history of contact of other, mashallah. What is your answers here? What is your action? Chest X-ray is normal, and nasopharyngeal swab came negative. Yes, yeah. One still pooling is there. What you will do? You will reassure the patient and send him home, or you will admit the patient to the hospital, or you will order the home isolation and start the treatment. Still 10 seconds for the pooling. Yes. Only for 50% are voted for these questions. Okay. Still pulling Ahmed or end? Yes. The result, 56% of the patient answer admit him to the admit him to the hospital isolation room, repeat nasopharyngeal and oropharyngeal swab and request CT chest, and 34% is for order home isolation and ask him if he's coming back if his symptoms are resolved, not resolved. The answer is C, admit him to the hospital isolation room, repeat nasopharyngeal and oropharyngeal swabs. Why? Because patient showing hypoxemia and highly febrile. Clinically, he's not okay, and that's why I need to observe him in the hospital. And the best is to repeat the nasopharyngeal swab for these patients and combined with oropharyngeal swabs. It will give you good sensitivity. I think this is last. This photo, a picture just for who doesn't know what is the transporting capsule for COVID patients. And this is a real picture from our hospital about transporting capsule for confirmed or suspected COVID patients. Yes, thanks. I'm ready to answer any questions from the participants. Ahmed Kuhail, are you with me still? Yes, any questions? I can see the chat.
Dr. Bashir, there was a question. What's the role of ultrasound in COVID-19 patients?
Okay. Ultrasound lung in the COVID patient is very important imaging modality because it's fast, short, can be done while patient in the bedside, and decreasing or minimizing the exposure for other healthcare workers, and can be done by trained physician. It's not difficult, and with what we are doing, as we say before, it's a point of care, means it's a short exam for 4 or 6 points, and it correlates with the findings, and it's giving me what I want to see in the CT scan. As we say, P line is common. I can discover a lot of information which is not there in the chest X-ray. I think we have to go with the ultrasound better than going with the CT scan. And yesterday was, as I mentioned, the big discussion from Dr. Salman, our colleague, about ultrasound and CT scan. CT scan is useful for patients who is highly suspected to have PE, macroembolism, or patients who are going to other reason for CT scan department for other part of the body, then I will request the CT scan. Otherwise, ultrasound is giving me good information and enough information about the lung parenchyma and even pleural fluids, pleural thickening from ultrasound.
So there's a question, also a comment from the previous lecture yesterday about focus as taking the priority to CT. But in clinical practice, actually, what do you prefer if you have trained who will do the ultrasound?
In clinical practice, if I have trained physician to do the ultrasound, point of care ultrasound, then I prefer clinically, even in the practice, the ultrasound. As we see, we cannot go in this lecture in details explaining how to do the ultrasound point of care, but findings is clear and correlating 100% with the CT scan. Then why I will go for the CT scan? Exposing our team and radiologist for patient with COVID. Ultrasound can be done even twice a day in the morning shift and the night shift, and I can see the improvements of my patients even through the ultrasound. If the P line become less, if the thickening is disappeared in the pleura, if the A line start to appear, then the patient most likely is recovering or the recovery phase. Another questions, Ahmed?
Actually, there is no more question.
Okay.
Thank you so much. Actually, it's very
thank you. Thank you for all. Thank you for you, for Dr. Madi, for Dr. Agul Takin, for the committee. And I hope by this course, end of this course, our physician in King Saud Medical City are able to approach or manage the COVID patient in our hospital and protecting themselves. Safety is very important. First, please protect yourself and then think about the management. Management is easy and we have the protocols in our hospital. Don't worry about it. Just protect yourself, please.
Okay, thank you so much. Just a reminder, tomorrow will be the last day, and at 9:30 we will start the exam. There is a 40 question. You have to pass 50% from the exam to get the certificate.
Good luck for all, and thank you again, Dr. Ahmed. Good luck.
Thank you. Bye-bye.
Good night. Good night.